Great. Yes, so welcome to the Aqua Training School. Just to say that we are a school, we have a vision where we want to see everyone achieving their full potential. We are an accredited school. This is some of the reasons why you would love us. These are some of the programs that we offer. I always want to encourage you to explore some of our free courses, especially the guidelines, which would really help you to understand in depth some of the discussions we have as part of these sessions. For today, you are welcomed, and I hope that this would be an enjoyable session. Today, we are going to look at the postpartum management of HIV. So there's the little one. Look at those eyes, very charming, right? So that's what we want to see. Remember, last week we dealt with the delivery, what needs to happen during delivery. So today the child is born and we want to take it from there. So what is important is the immediate management, after delivery. So all infants should probably be given to their mothers for skin-to-skin contact. We advocate and we recommend the initiation of exclusive breastfeeding. We also want to teach the mother about kangaroo mother care because that bond is very important for both the wellness of the mother and the child. And as soon as possible after birth, HIV-exposed infants. So if the child is born from a mother who is HIV positive, we call those children HIV-exposed infants. We want to initiate infant prophylaxis, but also to do a birth PCR. On the mother side, we would have done a delivery viral load as discussed last week. It's very important that we ensure that linkages to care are sorted out before the mother goes home. So this is a very high risk period where we can actually lose both the mother and the child. So it's quite important that we make systems in place to ensure that we ask women, if you are being discharged, where are you going to do your follow-up visit? And we make the necessary, bookings and systems to ensure that they are able to be received on the other side. And if there's any follow-up things that need to happen, we should document those in appropriate referral letters to ensure that there is at least good communication between the delivery side and the receiving side, right? Few seconds. I think I need to mute one or two people. May we all mute, please? Thank you. Yes. So women are usually discharged, same day after delivery, especially if there were no complications. It's important that the delivery viral load and the birth PCR results, are documented, and the barcodes are actually also included as part of the road to health booklet in terms of the child. The reason why this is important is to ensure that, remember, these two tests would have been done at the delivery site, but the follow-up would need to happen at a different facility. So at least if the barcodes are included in the key records that the mother will take to the facility, those results would be able to be tracked at that level, right? So here are some of the current recommendations. The first thing is that we've got two strategies in terms of preventing mother to child HIV transmission, especially in the postnatal care. The first strategy is to ensure that we minimize infant exposure to the virus, right? So how do we do that? Most of the work around minimizing the exposure of the child to a high virus is done in the antenatal component. So this, ideally, we want mothers to deliver with a suppressed viral load, right? The other strategy is that we want to ensure that all HIV-exposed infants receive some form of post-exposure prophylaxis immediately after birth. If these two strategies fail, we end up then with a child who's likely to be infected. Therefore, we have to institute systems for early identification of children who might be having HIV. And this is done through what we call early infant diagnosis, where we do a series of HIV tests from the birth PCR, 10 weeks PCR, and so on. And then once we identify a child as a child who has tested positive, we then start them on ART. At 6 weeks, all HIV-exposed children must be started on cotrimoxazole prophylaxis therapy. And in terms of PMTCT, we recommend and we promote breastfeeding exclusively for the first 6 months and then continued for up to 2 years. And we know that breastfeeding is associated with better survival and better growth in terms of our infants. So remember these two strategies. Always ask yourself, whenever you have a mother-baby pair, ask, is the mother, if the mother is positive, is the mother suppressed, And then if the child is HIV exposed, is the child on appropriate prophylaxis? And have we done our best to test the child so that as soon as the child tests positive, we are able to make the necessary follow-ups, right? So how do you choose an appropriate prophylaxis for the child? So the choice of the infant prophylaxis depends on the risk profile of the mother. And the key thing that determines the risk is the viral load. Are we dealing with a mother who is presumed suppressed or a mother where we suspect that the viral load is significantly high? Then the prophylaxis must be started immediately or soon after birth. So it's an urgent matter. As soon as possible, we should start appropriate prophylaxis for all HIV-exposed children. And we need to counsel the mother about her own ARVs, but importantly around the importance of giving the child this prophylaxis throughout breastfeeding, right? So the principles which are very, very important is that principle number one, the delivery viral load. Remember, all women, whether on ART, especially those who are on ART and known to be HIV positive, would receive a delivery viral load, right? And we use this viral load during labor to determine the risk profile of the infant, right? If the result of the delivery viral load is not yet available, right, we use the result of the most recent viral load, and we prefer a viral load that would have been done within 12 weeks of delivery, right? So if that viral load is there and it is suppressed, we would probably classify this mom, as a low risk mother. So that is quite important. The second principle is that we treat infants as high risk until proven low risk. This means that if at the time of delivery, we do not have a recent viral load that was done in the last 12 weeks, we do a delivery viral load, but we know that the results would come probably in the next few days, right? That infant, as soon as they are born, we would then start them on high risk prophylaxis. We will classify them as high risk, and therefore we need to intervene as a high risk scenario, right? Another key principle is that, yes, the guideline would say give nevirapine for 12 weeks, for example, but at 12 weeks, we would want to stop nevirapine where we believe that the mother has had enough time to suppress the virus, right? If at 12 weeks you still suspect that there's poor adherence and that maybe the mother has a detectable viral load, it is best at that point in time that you still continue nevirapine prophylaxis, at least until we have some confidence that the mother is suppressed. So remember these three principles as you manage children. So whenever you see a mother-baby pair, ask yourself, are we dealing with a low-risk mother-baby pair or a high-risk mother-baby pair? If it is a low-risk scenario, we talk about a viral load that is suppressed, right? And then a high-risk scenario, we're talking about mothers where we suspect that the viral load is significantly high. So, and this would include in situations where we do not have results of the viral load, right? Or where the last known viral load was detectable before delivery. Therefore, that child would be treated as high risk. Also, mothers who are on ART, but they were recently started. That means they were not exposed to ARVs long enough for their virus to be suppressed. We would then consider them as high risk, and we need to manage them as such, right? So as soon as you classify a patient or mother-baby pair as a low-risk scenario, then the child needs to get prophylaxis. They would get nevirapine daily for 6 weeks, right? Where you classify the mother as a high-risk mother-baby pair, they then get what we call a high-risk prophylaxis. That is dual prophylaxis. They would get nevirapine once daily for a minimum. That's why we use the word minimum. Remember, if at 12 weeks you still suspect that the mother is not suppressed, we might continue longer than that. And then also in combination, you give nevirapine in combination with zidovudine for 6 weeks. So that's quite important, right? And so so in terms of infants who need additional prophylaxis, who are these infants, right? So nevirapine for 12 weeks plus AZT for 6 weeks. These are what we would classify as high risk mother-baby pairs, right? That means we are looking at mothers who have not been on ARVs long enough to be suppressed. So for example, yes, she's on ART at the time of delivery, she was on ART, but she recently started. She started less than 12 weeks. So if she was 6 months on ARVs, we would presume her to be suppressed. Diagnosed for the first time in labor, so she came in without knowing her status. Mother is unbooked, so we don't know. She has never booked for the antenatal care visits. She's diagnosed for the first time during breastfeeding and still breastfeeding. So she was previously negative. During breastfeeding, for one reason or the other, she's offered a test and then she tests positive for the first time. These kinds of mother-baby pairs will be regarded as high risk for HIV transmission. Therefore, the baby will get a dual prophylaxis, which is nevirapine and AZT. And then on this side now, remember there are women now who would be on ART for more than 3 months, but they have a detectable viral load, right? So our concern here is not just an issue of a high viral load. We are concerned that this mother had been long enough on ARVs and she's not suppressing. So our concern is that her viral load is high, but she might have resistance. So we are worried that she might transmit a very bad bug to the child. So for these women, we give nevirapine for 12 weeks and AZT for 6 weeks. Especially if they are breastfeeding. If they are not breastfeeding, we can actually give both prophylaxis for 6 weeks, right? So in summary, in terms of infant prophylaxis at birth, you must always be in a position to classify women as either low risk or high risk. And if they are high risk, you need to assess whether the mother is breastfeeding or not, right? Because women who are breastfeeding, it means there's ongoing exposure to HIV through breastfeeds, right? If the mother has opted for formula feeding, it means, yes, at the time of birth, the child was exposed, but there won't be any ongoing exposure because the child is being formula fed. So you would see that low risk, we talk about a delivery viral load that is suppressed, and we would want to give nevirapine at birth continued up to 6 weeks. When it comes to a high risk situation, it's at birth, we are talking about women who are presumed to have high viral loads. We would then give them the child, when the child is born, we would give a zidovudine twice daily for 6 weeks and nevirapine as a daily dose for 12 weeks, right? And you can see here, we say stop nevirapine only after confirmation that the mother is suppressed, right? Or until 1 week after cessation of breastfeeding. So if she's no longer breastfeeding, but she's got a high viral load, we can stop the prophylaxis because the child is no longer exposed to the mother's high viral virus, right? All children where the mother during delivery, the mother has a high viral load, they are classified as high risk, but the mother is not breastfeeding. She's exclusively formula feeding, right? The prophylaxis is still zidovudine and nevirapine, but both are given for 6 weeks. So it's quite important to differentiate these two. Breastfeeding is our feeding option, our best option. So we should all become advocates for breastfeeding because we know it is strongly linked with child survival. So during breastfeeding, we've got two kinds of women. We've got women who are HIV negative, right? And those who are HIV positive. Those who are HIV negative, our role is to look at HIV risk reduction and ensure that we keep them as negative as possible. And where possible, we regularly offer the HIV testing during each immunization visit, at least, right? If she is HIV positive, she needs to be on ART and she needs to be suppressed. And both options would then make breastfeeding to be safe in this context. Remember, if she's HIV negative, and during breastfeeding, she becomes HIV positive whilst breastfeeding, it's a significant risk factor because both the mother and the child would not be protected at that point in time. So again, for HIV negative women, our priorities are HIV risk reduction, regular HIV testing every visit whenever you come into contact with them, and then infant feeding support to ensure that they are able to continue to provide exclusive breastfeeding. If she is HIV positive, the mom is living with HIV, it means the child is exposed. So we want to make sure that the mother is on ARVs and she's virologically suppressed. We need to ensure that the child is on appropriate prophylaxis and that we continue to test the child, because as long as the child keeps on giving us a negative test, we schedule the next test, as per the schedule that I will share with you. Risk reduction also includes assessment of sexual partners and other children at home who might be living with HIV, and we need to encourage exclusive breastfeeding across the board, right? So you remember we discussed these two strategies, that the strategy one is to suppress the viral load and strategy two is to give infant prophylaxis. These two strategies are still very relevant during breastfeeding, right? So if you've got a mom who's living with HIV and AIDS and she's breastfeeding, we prefer that she must be on ART and suppressed. If she is not suppressed, the child must be on appropriate prophylaxis. So just remember, you should never leave the child unprotected where the child is not on prophylaxis and the mother still has a detectable viral load, right? The essence is that you can only stop the prophylaxis where the mother is confirmed to be suppressed or where she has taken ARVs long enough for us to have high confidence that she is suppressed. So that is quite very important in this instance, right? So remember, whenever you've got a mom who is newly diagnosed, so she's breastfeeding, she was negative all along, and you do an HIV test which comes back positive, or she is known on ART with a high viral load, both mothers need to be, this mother needs to be put on ARVs. Here we need to assess why the mother is not suppressing while she's on ARVs, but the child would be classified as high risk, and therefore we need to provide a high risk prophylaxis, which would be nevirapine for 12 weeks and AZT for 6 weeks in this instance. So if you've got an 8-month-old child whose mother is breastfeeding and the mother tests positive today, that child requires dual prophylaxis at that point because there's a high risk that the child would become infected without any intervention, right? So remember, we spoke about mothers must be suppressed. Number 2, the child must be put on appropriate prophylaxis. 3, we need to ensure that we identify infants who do become infected in time, right? Therefore, our strategies is to timely, what we call early infant diagnosis. The first thing we do is a birth PCR for all HIV exposed babies. We therefore move on to also do a 10-week PCR for all HIV exposed babies. Just a few seconds so that I can mute, because I think we've got someone. Yes. Yes, I hope that is helpful. Yes, so I was saying that, remember, a birth PCR is for all HIV exposed babies, a 10 weeks PCR for all HIV exposed babies, as long as they are not on ART. So we don't test infants who are on ART, right? So the schedule is birth followed by 10 weeks, followed by 6 months, right? PCR. At 18 months, we do a rapid test, right? And the next test would be done at 2 years, right? In between, if the mother stops breastfeeding earlier, we would then test the child 6 weeks after breastfeeds have been stopped. So just remember that. So if we ask you what is the testing schedule for infants who are exposed to HIV, you'll say birth, 10 weeks, 6 months. These 3 are PCR tests, then 18 months rapid test. And then anytime when she stops breastfeeding, you count 6 weeks. And then you would then do an age-appropriate test. If the child is less than a year, you'll do a PCR. Above a year, you might do a rapid test. And then remember, we don't just test children based on the schedule. Anytime a mother brings a child who's not well, oral sores, oral candida, whatever problem they have, we have to offer an HIV test. We cannot wait for a scheduled test and say, no, we'll test you at 10 weeks when the child is sick today, right? And then lastly, at 2 years, we then do a confirmatory rapid test at that point in time. So just remember the changes as I've showed you there, right? So the care of an HIV-exposed infant after birth, remember, during the 3 to 6 days visit, we have to follow up on the birth PCR, if it was done, to check the results, but also check if we are giving the correct dose of the prophylaxis for that child. During the 6 weeks immunization, we still check whether the birth PCR results were reviewed last time. We check the viral load of the mother, just to ensure that things are still in order. During the 10 weeks visit, we will do a PCR. 6 months, we do a PCR. 18 months, we do a rapid test. And then also at 24 months, we would do a rapid test. You can test the child anytime when the child is symptomatic. You don't wait for this schedule. And then also when the mom stops breastfeeding, you can do a test 6 weeks after the breast feeds were actually stopped. So don't forget. And also during the 6 weeks visit, that's when we also start all HIV exposed infants on cotrimoxazole prophylaxis therapy. So remember, in terms of testing, if the child is less than 18 months of age, the first test is a PCR test. If it's positive, we start them on ART and do a second confirmatory test as a PCR, right? Between 18 months and 2 years, we do a rapid test, the one that we use for adults. And if it's positive, we confirm it with a PCR, right? If it's more than 2 years, we diagnose the children with 2 HIV rapid tests at that point in time, right? So I hope you are still with me. I just want to clear these drawings here, right? Okay, let me close a few seconds. I don't know, a few seconds. All right, I think we're okay. So how do you respond to PCR results, right? So if your PCR, you do a PCR at birth or 10 weeks and it comes back negative, you just reinforce adherence and show that the mother remains suppressed. If the child is on prophylaxis, they continue, but we know we have to test the child again at 6 months, 18 months, and 24 months, right? If the PCR comes back positive, we do not delay the starting of ARVs. We prepare the child for ART. We start ARVs as per the universal test and treat principles, hopefully same day, especially if the caregiver understands and they would want their child to be on ARVs. So we start the child on ARVs same day. However, we do a second confirmatory test, right, at that point in time. And if the second test comes back positive, we have 2 positive tests, we just continue ARVs. If the second PCR comes back negative, you might need to do a third PCR test or even a viral load at that point in time to confirm the HIV diagnosis of this child, right? Where the results come back indeterminate, you need to call the child back again and ensure that you are able to repeat those test results, right? So remember, HIV exposed children, infants, they are at a very high risk of many things, high risk of growth deficits, neurodevelopmental delays, infections, including mortality, death. So remember to treat these children comprehensively. Make sure that they get, their immunizations, that they are always assessed in terms of nutritional status, assess them whether they are growing well, if they've been admitted before. And remember, if they've been admitted for whatever infection, you might need to do the HIV test again. Check also the mother. Remember, if the mother doesn't do well, there's a very highly likelihood that this child would not do well. So remember, HIV exposed but uninfected infants are always at the high risk of very negative outcomes. So that's what we want to look at. Now, in terms of some of the scenarios, when a mother is failing second line, so the mother is on ART, she's taking standard second line or even third line ARVs, right? So she's taking very complicated drugs and she's failing those specific drugs. We do not want these mothers to breastfeed. So this is where you are able to prescribe infant formula because it will be medically indicated, right? However, if formula is not available, she can continue to breastfeed, but she must do it exclusively, and so on. But we know that in South Africa, we have made formula available for all women who've got high viral loads taking second line or third line ARVs. Remember, if she's got a high viral load on first line ARVs, the recommendation is that she must continue to breastfeed. We need to make sure that the infant is on appropriate prophylaxis, and we try to resuppress in terms of switching the drugs or adherence the mothers as soon as possible. So just remember this part, right? Another group is your orphaned and abandoned infants. So which it was the earlier question which I asked to say, when you have an abandoned infant, so they bring a child to you, the mother is not there, what do you do? So the key thing is to treat them as high risk, As soon as you say high risk, it means this child must be started on nevirapine and zidovudine. But remember, this child, the mother is not there, so this child is not being breastfed. So we don't need to continue nevirapine for 12 weeks. The child will get both these drugs for 6 weeks, right? And then we need to do our early infant diagnosis by performing a PCR test with a rapid test at the same time. A rapid test on its own is not reliable at this point, right? So that's why we also want to do a PCR. And based on the results of your PCR results, you then act. So if the PCR comes back positive, we stop the prophylaxis and we start the child on ART. If the PCR is negative, we know that we have to do it again when the child is 10 weeks, and then that will be 4 weeks after the prophylaxis has been stopped. And the 10 weeks PCR would then be the one that tells us the final outcome of this child, since the child is not being breastfed, right? So don't forget the other things. For example, make sure that when you discharge women, after delivery, they have sufficient ARVs. Ensure that the mother has good knowledge in terms of her ARVs, the prophylaxis to the child, the importance of exclusive breastfeeding, and the kinds of follow-up visits that she would need to do. Infant feeding for us is that we recommend breastfeeding unless if medically we cannot give breastfeeding, including mothers who are failing second line and third line, then we can then support the mother with formula feeding. In the public sector, she doesn't have to buy. It should be prescribed as part of the treatment for the child. However, breastfeeding, where it is started exclusively for 6 months, complementary food introduced from 6 months and continued for 24 months, irrespective of the mother's HIV status. Breastfeeding is the recommended feeding option for both HIV positive and HIV negative mothers, right? It's very important that when you see a child, think about the mother, because usually when children are not well, their mothers don't care about themselves, right? But me and you, we know that if the mother is not well, this child might not even do well. So if you see a child, think about the mother. If the mother is not well, ask about the children. And we need to ensure that in our care, both the needs of the infant and that of the mother are addressed all the time. It's quite important. So you see the mother, think about the baby. You see the baby, think about the mom. And your care should be comprehensive. So if it's a 6 weeks visit, don't just focus on the PCRs and the HIVs. The child needs to get her immunizations. If they are unwell, you need to follow the IMCI or your integrated management of childhood illnesses and ensure that they are treated very well. If the mother is not well, follow your adult primary care guidelines, you know, to ensure that the mother is supported, you know, as needed. So these are things that are very, very important that we should not miss. You know, like make sure that the 6 weeks pap smear is done. The nutritional status of the mother is always checked. You screen her for TB. If she's got symptoms, we investigate. If it's TB, we treat it. You know, we want the mother alive at the end, and we also want the child to be alive. Remember, the baby at 6 weeks, all HIV exposed infants must be started on cotrimoxazole. So that's important. You know, we need to make sure that growth and nutritional assessment, including developmental milestones, are always assessed, and we know exactly what is the HIV status of the child, right? In terms of the PCRs and tracking those results. So it's quite important. And unfortunately, our women, they move between facilities, and even within a facility, they move between cubicles. So it's very important that we try to improve the processes and ensure that the process is not cumbersome for the mother, and we ensure that there's continuity of care. So if the mother is seen at facility 1, when she gets to facility 2, she should have the right records to communicate whatever health needs, you know, she might have at that point in time. So the road for the mothers generally is not an N4, N3 road, you know, N1 road. It's quite a very hectic road. If you think about where we started antenatally, you know, in labor, now we are in the postnatal care, the mother is still on the journey. So it's our responsibility to smoothen the road, to support the mothers, you know, hold them by the hand and ensure that they feel supported at that point in time. So it's quite important that, to be honest, it's an injustice and a violation of human rights for any child to be born with HIV today, because it is preventable. But once someone gets it, we can't do anything about it. It's incurable. So let's do our best, even before conception, to intervene, increase access to family planning, preconception counseling and support, antenatally, ensuring that women book early and they are supported. In labor, let's not miss anyone. Let's provide HIV testing for any mom who's not on ART. And if they're on ART, we do our viral loads. Immediately after delivery, we make sure that we test children, birth, 10 weeks, 6 months. We start appropriate prophylaxis. We care for the mother, keeping her alive. We care for the child, keeping the infant alive, you know, until the journey, you know, at the end, and we win this battle, right? So what I would like to do at this point in time, maybe, yes, I think I still have time today. So let's do that. Hey, what did I do now? Anyway, I think I've messed up. Okay, let's see. A few seconds. There we go. Yes, so let's look at these scenarios just to help you say, just to put it all together. So here's a scenario one. This PowerPoint is not the one that I had opened. Few seconds. Yes, sorry. So here's a case which we discussed a bit last week. So it's Tepo, who is brought to your facility for testing. He is underweight but does not appear ill. The maternal history is unknown. So he's an abandoned child, right? I'm hoping you are thinking with me, what is it that you would do for this child? Number one, the child might be hungry. The child needs food. The child might be hypothermic. The child needs to be kept warm. The child needs to be properly assessed and examined. And if there's anything that needs to be treated, you know, we treat it, right? And if she needs fluids or to be resuscitated, we resuscitate the child, right? In terms of HIV care, two critical things need to happen immediately here. One, we must start prophylaxis. What type of prophylaxis? Low risk or high risk? High risk prophylaxis. That is a combination of nevirapine and zidovudine. For how long? Both of them for 6 weeks, right? Why not nevirapine for 12 weeks? Well, the mother is not there. This child is not going to be breastfed. Nevirapine is extended from 6 weeks to 12 weeks for high-risk infants where the mother is breastfeeding. So let's remember that part. And then we must test the child with what? Two tests. Which ones? PCR and a rapid test. And then based on that PCR, if it's positive, we want to prepare the child for ART. If the PCR is negative, we then want to support the child to continue the prophylaxis and repeat the PCR during the 10 weeks visit. That 10 weeks visit PCR, if it's negative, the child is negative forever. If it's positive, we then prepare the child for ART. I'm hoping that you are following. Here's a second case. Tandi is a 6 weeks old HIV exposed infant, right? With a suspected HIV related disease who comes in for testing at your facility. How would you manage Tandi, the 6 weeks old HIV exposed baby? What we know is that a birth PCR was done, which was negative. The child is currently being breastfed, and the child was started on nevirapine, right, at birth. So at birth, it seems like things were okay, right? But there's a history of the mother that the mother was diagnosed 2 weeks before delivery, right? So, and the mother is on a fixed dose combination, whether DTG or TE. So how do you manage this? Well, we have to manage both the mother and the child. Let's start with the mother. The mother is on ARVs now because she was 2 weeks on ARVs during the delivery or birth. And now the child, so now the mother is on ARVs for 8 weeks, right? Which is something like 2 months, right? So it's not adequate, right? However, we support the mother. We make sure that she understands about her ARVs. We make sure that she understands about why she must give the child the prophylaxis as prescribed. We check her wellness. If she's healthy, she's okay, no complaints, we are good. If she's not well, we follow our algorithms based on adult primary care or whatever guidelines you want to use. It's a 6 weeks visit. She's due for a pap smear. Don't forget the wellness of the mother. She's due for a pap smear at that point in time. So quite important. Viral load wise, I presume they didn't do a delivery viral load because she was 2 weeks on ARVs. It was going to be high anyway. But she's due for a viral load next month. Remember in PMTCT, when do we do viral loads? 3 months from the time when ARVs were started. So in the next 4 weeks, yes, in the next 4 weeks, she will be due for a viral load. So during the 10 weeks visit, let's come back to the child. So this child was not managed correctly. Why? If the mother was on ARVs for 2 weeks at the time of delivery, was this child low risk or high risk? The child was high risk. Why? Because the mother got less than 12 weeks of ARVs. So high risk. High risk, what type of prophylaxis? Dual prophylaxis. This child was supposed to have been given nevirapine and zidovudine from birth. Nevirapine for 12 weeks because the child is being breastfed, and zidovudine BD for for up to today, 6 weeks, right? So we might need, we are not going to stop this nevirapine, today, because the mother is not yet suppressed in our thinking, right? So we will have to add that zidovudine. We will have to continue nevirapine for another 12 weeks. I mean, up to when the child is 12 weeks. So that is what we are going to do. But there is a problem. Thandi has a suspected HIV-related disease today, right? We had a birth PCR in terms of PMTCT. The next PCR is supposed to be at 10 weeks. But the child is sick today. We can't wait. Remember, anytime the child is symptomatic, we must do a PCR. So we'll do a PCR today on this child. Because of that, we will probably, there's no evidence, but we are likely to add zidovudine and continue nevirapine for 12 weeks. That's what I'll probably do, because the mother still has a high viral load. That's what I will do. And it's a 6 weeks visit. She must get immunizations, this child. We must assess her growth and development. What else? 6 weeks, 6 weeks, 6 weeks. What else must you prescribe? Cotrimoxazole prophylaxis therapy. Why? Because the child is HIV exposed. All HIV exposed infants at 6 weeks, we must start them on cotrimoxazole prophylaxis therapy. So you manage both the child and the mother, and then you open your IMCI guide, and then you manage whatever HIV related. If it's candida, you manage as per the guidelines. If it's diarrhea, you manage. If it's TB, you manage as per the guidelines. Right. Last case scenario, baby Mike. So baby Mike is an HIV exposed baby. Baby Mike is 8 months old and he comes to you. He's okay. The issue is the birth PCR for Mike and the 10-week PCR were negative, right? We don't have the 6 months PCR. So it was not done. Ideally, it should have been done because he's an HIV exposed baby. Mike is being breastfed, but the issue we have with Mike is that the mother is on second line ARVs and the mother has a viral load that's more than 100,000, right? So what do? Separate them. Have a plan for the child, have a plan for the mother. Let's start with the child. Baby Mike, what do? Baby Mike is being breastfed and is now exposed to a high viral load, right? We don't know from when. So number one, we need to test baby Mike today because we don't even have the 6 months viral load. Even if we had it, I mean the 6 months PCR, today we have found out that he's now exposed to a high virus. So what do? You do a PCR today. That's number one. Number two, is baby Mike low risk or high risk? He is high risk. Why? Because he's being breastfed a milk that has a high virus. So dual prophylaxis. What is that dual prophylaxis? Zidovudine and lamivudine, right? But there's another thing we must do. We need to talk to the mother and encourage her to stop breastfeeds. Why? Because when a mother has a high viral load, but on second line or third line ART, right, it's a medical indication for us not to recommend breastfeeding, but also to support and prescribe formula feeds. So for this child, we prescribe formula. We do a PCR today. What else do you want to do today? You start the child on dual prophylaxis. Yes, he had completed before, but the mother was suppressed at that point in time. Now we have a mother with a high viral load, right? Then you have to help with the mother. What do you do with the mother? One, counseling and support. Two, understanding why is her viral load up. Is she taking her medicines? Is she missing doses? Is she experiencing side effects? Drug, is she taking other drugs that might interact with the ARVs, or has she developed, resistance, right? As part of that, you help her to understand that you have re-prescribed the prophylaxis for the child and you would want her to give it at least for 6 weeks, right? And then that you will support her, refer her to a dietitian, but also give her tips on how to stop breastfeeds, because she has to stop breastfeeds. Then give her infant feeding education around formula and how to do it safely. And then we check her if she's got any health needs. we manage that as that. Then this viral load, we will repeat it again in 1 month's time. If it is still high, you would then have to refer her to an HIV clinic. Remember, this is second line. From a NIMAR perspective, you can switch patients from first line to second line. This one is failing second line ART regimen. So you are not going to be able to switch her. She would need a resistance test and many other things. So you would refer her to a clinic where there's a doctor who's very familiar with things around HIV/AIDS and its management. Right. Yeah. So just before I ask you to make comments, I want to repeat this just a few seconds. Yes, there you go. It's that those two questions. I want to see if your answers will be different at this point in time. Can you engage with the test there? The question, sorry. Yes, can you see it? Can we all vote, please? Choose your answer. You can choose more than one answer, but please remember what you have just been taught. Otherwise, we are restarting the session. Right. Otherwise, we are restarting. 10 more seconds, and then I will stop and show you the results. Then we can have a discussion. Come on, vote, guys. Some of you are not choosing. Choose, please. Be engaged. 3, 2, 1, and then I stop. Right. So let me show you the results. So we are talking about an abandoned child, and I'm asking, what do you do? So I see all of us, we are agreeing that an abandoned child is a high-risk scenario, right? That's where it starts. You treat the child as high risk. But what does that mean? Number one, you have to test the child and you have to give prophylaxis, right? This child here, in the old guidelines, you would do an HIV rapid test only, but I've just showed you an algorithm. I don't know if this thing would allow me to show you that algorithm again. Yes, remember I showed you the algorithm that one, you start the child on nevirapine and AZT. So if you say nevirapine, it's not wrong, but the problem is you are saying nevirapine only. So we have to give nevirapine and zidovudine to this child. As long as you say high risk, you give 2 ARVs as prophylaxis, right? And then in terms of testing, there it is. You do your PCR and your HIV rapid test. So that you do those 2 tests, and then you win as such, right? So the correct answers are to do an HIV rapid test and a DNA PCR. You start the child on nevirapine and zidovudine, and you treat the child as a high-risk HIV-exposed infant, right? And then let's do the last one, which we did the other time, and then let's see what your answers are going to look like. That's the last one for tonight. We are almost done. We're actually done. It's just read it carefully and select the best answers. Come, Bosista, Ozani. Yes, let's engage, please. I know it's family time, you're exhausted. This is just one last mile. 10 more seconds, and then we stop the voting. Come on, let's do it. Let's do it. Choose my kettle. Right. Choose my kettle. Where is that slide? Yes. All right. So I'm gonna pause it there, and I'm going to show you the results. So here we're talking about a child who's been breastfed. Which of these scenarios would you classify them as high risk and therefore give dual prophylaxis, right? Let's look at the first one. The mother is newly diagnosed Do you think the mother is suppressed? No, the viral load is high. Therefore, that's correct. Mother is not on ART. Yes, we do that. Mother received less than 12 weeks of ART. Yes, dual prophylaxis. Mother is on lifelong ARVs at the time of conception. Probably not, especially if we have the recent viral load and we believe that the mother is suppressed, right? Mother is on ART. The ART was started more than 12 weeks before delivery, and we have a viral load that she is suppressed, right? So probably not. So the first three scenarios are the ones where we have a very high index that we should give dual prophylaxis. The bottom two, it just depends on quite a number of things. So yes, we leave it at that. So yes, so thank you very much for taking time to listen. Just one slide which summarizes the whole thing we discussed today, and then I will then stop. I hope the cases were here. So this is the summary slide of the topic to say always assess the risk profile, based on antenatal, in labor, and postnatal, so a low risk mom, antenatally, she has booked early and she's on ARVs and adherent, right? And she's got a suppressed viral load. As you can see, the infant during delivery will get a birth PCR, In the postnatal state, we continue to monitor the mother's viral load. The child will get nevirapine only for 6 weeks. And during the 6 weeks visit, we will start cotrimoxazole. So we want 100% of our mother-baby pairs to go through this green journey, right? Unfortunately, we do get high-risk mothers who have a detectable viral load at the time of delivery, where then the infant is classified as high risk and they need to get dual prophylaxis, zidovudine and nevirapine, zidovudine for 6 weeks, nevirapine for 12 weeks. And we need to make an effort to ensure that the mother gets suppressed, as soon as it's possible. Yes, so thank you very much for your time. I hope this session was worth your time and you have learned something out of it.